Hello everyone, happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note whether I am audible and visible, everyone. All right. Hi. Good evening, Ashfaq, Dr. Nissi, Yogesh, everyone here. So a very warm welcome. So here we are in the today's YouTube live session where we are going to discuss some interesting integrated radiology MCQs, which will also give you a quick glimpse into the updated PrepLadder question bank. So all these questions are going to be integrated like radiology and clinical integrated, pharmacology integrated. Yes, hi, good evening everyone. I can see Vikas, Rishabh, Indu, Dr. Z, Gangaram, Jaideep, Harika, Sandeep, Mahesh, Black Panther, everyone here. A very, very good evening and a happy evening. So get ready to discuss some interesting integrated clinical MCQs as I was saying. And before I start with the discussion here, one thing that I would like to tell about, because it's a common feeling that all of us go through, there are some days where we don't feel good and we don't feel like studying, or we are not able to complete the daily target, and that definitely makes us feel frustrated and irritated, and not so good is we start feeling to the extent that we are good for nothing. So today's thought for the day is basically the food for the soul and the mind is, remember, if you cannot fly, then run. If you cannot run, then walk. If you cannot walk, then crawl. But by all means, keep moving, right? That should be the motto of your life, and basically that should be the motto of every single day that you are gifted with. So make the best use of it as much as you can. Like I said, if you are an intern, if you are working, you might not get the same amount of time every single day, but at least what you can do is कि जितना time मिला, I am making the best of it. I am not wasting that time, right? So be honest to yourself and play your role, and I'm pretty sure that one day you would definitely reach your goal. And surprisingly, that has become so rhyming, right? Hi, good evening, happy evening everyone. I can see Nihar also here, Suresh, Shikha, Mushahid and Free Prep, everybody here. So let's start with the discussion of the today's questions, and before that, I'm sure that all of you are subscribed to the PrepLadder YouTube channel. If not, make sure you are, because I don't want any one of you to miss on any of the high yield videos that we keep sharing on the channel, be it the live sessions or be it the recorded videos. And yes, of course, do not forget to show your love by hitting the like button for this video as well. That's an indirect indicator of how much love is being showered. Right. So, Dr. M. Kumar, feeling nervous. Why? Are you giving the upcoming FMGE exam, is it? Because I'm pretty sure it's only when the exam is very near, we all of us start feeling that nervous and anxious. If yes, right, if yes, so all you need to understand is, try to control things which are in your control, right? मेहनत करना, पढ़ाई करना is in your hands, is in your control. Result कैसा आना है, that is not in your control. Exam paper difficult आएगा, easy आएगा, वो आपके हाथ में नहीं है. हमारे हाथ में है कि हम सिर्फ रोज मेहनत कर रहे हैं और पढ़े, right? So that is the only thing that we can do. So make sure you are doing that, right? Okay, so let's start with the today's discussion. Need some strong motivation for consistency and concentration. One thing that you can always remember, that every minute that you are wasting, remember that your competitor is solving one extra MCQ and getting one extra question right in the exam, and I'm sure that you know that one question here and there means difference of how many ranks, है ना? So बस हमेशा जब कुछ पढ़ाई करने का मन नहीं है तो सोचना कि वो मेरा competitor दोस्त is studying and I need to move ahead, right? So let's start with the discussion, guys. This is the first question. Identify and match the arteries in the following image of the circle of Willis. Thank you so much, Nehar. Thank you so much. My guinea pigs are also here. Chalo. Then let's see who gets this right first, and at the end basically we will get to know ki who got the right answers first consistently in the today's session. तो देखते हैं ये सबसे पहले right answer किसका है. Identify and match the arteries in the given circle of Willis. Why? Answer is already given because it's my bad, Mustafa. You know, you can have good examiners like this जो already आपको indicator दे देंगे exam में कि this is the answer, and this has actually happened in the recent INI-CET exam as well, जहाँ bracket में लिखा था कि this is the correct answer, right? So my bad. This is, yes, the correct answer here is A. Okay, the correct answer here is A. First of all, chalo, now let me ask the questions which are not given here. What investigation is this? Is it a CT angio? Is it a MR angio? Or is it a DSA? What investigation do you think is this? Yes, is it a CT angio? Is it a MR angio? Or is it a DSA? Very good, amazing. So this is MR angio, very good. This is not DSA. Guys, remember that. How are you seeing the vessels here? The vessels here are appearing white. You are not seeing just one vessel here, right? You are seeing the vessels of both the sides. In DSA, it is one vessel at a time, or at least one side vessels that you would see. You will not see all the vessels together. Plus, here all the vessels are white. Generally, for your exam, remember that in DSA, the vessels are going to be black. DSA has black vessels. It is done under fluoroscopy. This is MR angio. This is not CT angio. Why is this not CT angio? Because you are not seeing the white bones, right? You are not seeing the white bones here. That is why this is MR angio. Now, let me zoom in this image and show you the vessels here. So, look at this vessel labeled 8. These are the two vertebral arteries, the posterior circulation of the brain, the vertebrobasilar circulation. So, these two are the vertebral arteries which fuse to form the basilar artery, right? That's the basilar artery there. Now, if you trace the basilar artery there, if you look at the basilar artery there, the vessel that you are seeing there, the terminal branch is the posterior cerebral artery. Okay, that's the posterior cerebral artery. This tortuous vessel, another large vessel that you are seeing supplying the brain, that's a vessel of the anterior circulation, and that is basically internal carotid artery. So remember, internal carotid artery has the tortuous course, the siphon, right? And that's the internal carotid artery. The terminal branches of which are going laterally is the middle cerebral artery. Going anteriorly is the anterior cerebral artery, right? So what do we have? Going laterally is the middle cerebral artery, and anterior is the anterior cerebral artery, right? This artery here connecting the ICA with the PCA, coming from the ICA, right? It comes from the ICA. That is the posterior communicating artery. Okay, posterior communicating artery. Mustafa, circle of Willis याद करने के लिए कोई mnemonic? I'll tell you few tips and tricks, few mnemonics on that. Okay, so remember that. Now talking about summarizing this basically. Okay, so let's try to summarize this. We have the cerebral arteries and we have the cerebellar arteries. Cerebral arteries and the cerebellar arteries. So remember that the cerebral arteries are the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery, right? Now what are these branches of? So remember, the anterior and the middle are the branches of internal carotid artery. So this you can remember as AIM. What is AIM? Internal carotid gives ACA and MCA. Internal carotid gives ACA and MCA. Posterior cerebral comes from the posterior circulation. So P, B. Okay, P and B, they sound similar phonetically. So remember, this is from the basilar artery. The PCA is from the basilar artery. Done. Now coming to the cerebellar arteries. In the cerebellar arteries, which one do we have? We have the superior cerebellar arteries and we have the inferior cerebellar arteries. Even in the inferior cerebellar arteries, we have the anterior inferior and we have the posterior inferior. That is ICA and PICA. So what is the superior cerebellar artery a branch of? What is this ICA a branch of? So again remember, the first two here, the superior cerebellar and the ICA, these are the branches of the Basilar artery. Cerebellum is niche, the posterior fossa. So it is supplied by the posterior circulation. Very good, Dr. Harika. You remember the mnemonics, right? And pica is a branch of vertebral artery. So this you can remember, write down basilar as pacillar. Basilar is basically pacillar. So what are the branches coming from the basilar artery? Is the PCA, the ICA and the SCA. These are the branches coming from the basilar artery. Pica is a branch from vertebral artery. I hope all of you remember the blockage of the pica or the vertebral artery gives the Wallenberg syndrome, the lateral medullary syndrome, which helps you remember that pica is a branch of vertebral, right? Look at this schematic diagram, basically helping you understand this. So the two vertebral arteries joining to form a basilar. The terminal branch is the PCA. The second last branch coming from the basilar is the superior cerebellar artery, right? The superior cerebellar artery, and niche wale part se you have the ICA, okay? That is your ICA, right? And then you have the internal carotid artery giving the anterior cerebral artery and the middle cerebral artery. The internal carotid artery gives the middle cerebral artery and the anterior cerebral artery. Also look at this ophthalmic artery coming from ICA. The anterior choroidal artery also comes from the ICA. Okay. Is this clear with everyone? This image of MR angio. Hi Revti, glad to see you here. So which is the structure labeled A? This is the structure labeled A. So this is ACA. So in our answer here, A is C, right? A is C. So option B is ruled out. When in INI-CET exam, you have options like match the following. Rule out करते जाओ कि A का C है, इसमें A का C नहीं है तो ये गया. B वाला कौन सा है? Which is this B1? B is the middle cerebral artery. That means B is D. So B is D is only in the first option. So the rest of the options are automatically ruled out. So remember that in your match the following, you need not know all the answers, right? Even if two you know, you can rule out the rest of the options and you can come to the answer. That is what is called as the topper's tricks, right? So that is how, the toppers get the answers right. Hi Manshad. Chalo, let's go to the next question now. Tell me, this is an easy one. What do you think will be the answer to this? Parul. I mean, the examiner should not be so sadist to give you both the options in the question कि vertebral है कि pica है. एक select करना है तो vertebral is more common than the pica. Very good. So Mahesh has got it right first. Then we have Yogesh, Priyanka, Dr. M. Kumar, Mukesh Kumar. Right. Now, again, a trick here, right? The insiders, a topper's trick here, basically to get the answers right fast. When you have image-based questions, if the image is a giveaway, like you know कि ये तो दिख ही रहा है कि ये popcorn calcification है, तो ये fibroadenoma है. Read the last line of the question. That is, what is the most likely diagnosis? It is fibroadenoma, right? So what you have to see is in image-based questions, the sequence is image देखो, options देखो, last line देखो, and then decide the answer, right? So this is fibroadenoma because of the popcorn calcification. Now let's have a look. Let's say कि image नहीं समझ रहा है. So can the clinical history help? Definitely. A young female presenting with a painless lump. There's no pain there. It is mobile mass. It is called the mouse in the breast. It is very mobile, right? It has a smooth and well circumscribed margins on ultrasound. That tells you that it is a benign lesion. So this tells you it is fibroadenoma again, right? It is fibroadenoma again. So even if you are not able to identify the image, then the clinical history will help you in that case. So look at the ultrasound image. What are you seeing in the ultrasound is, this is a hypoechoic lesion, very well defined. And is it wider than taller or is it taller than wider? How is fibroadenoma? Is it wider than taller or is it taller than wider? You can see here it is wider than taller. Okay, it is wider than taller. On ultrasound, okay, on ultrasound, a lesion which is taller than wider is what is suggestive of a malignant lesion. Because understand the concept is, A lesion which is taller than wider means it is going into multiple planes. It is invading the planes and going into multiple planes. So that is taller than wider and it is malignant. A lesion which is wider than taller basically is spreading in the same plane. If this is the plane, it's spreading in the same plane. So it is benign. So remember that wider than taller is benign and taller than wider is malignant. Absolutely right. So the answer here is fibroadenoma. Okay. For ductal carcinoma in situ, DCIS, what is the most sensitive investigation for DCIS? What is the most sensitive investigation for DCIS? It is MRI. Okay, remember it is MRI. So in high risk females who have family history, who have BRCA gene positive, we do MRI for screening. Otherwise, in our average risk females, we do mammography. Very good. Right. Tell me what is this? When you see the popcorn calcification in the lung, recent FMGE exam question as well. Popcorn calcification in the lung is a feature of popcorn calcification in the lung. Very good. That is pulmonary hamartoma. Okay, that is pulmonary hamartoma. So you can remember this as Hamara tomara popcorn, that is Hamar tomar popcorn. So Hamar tomar has popcorn calcification. Okay. And where do you have popcorn calcification in the MRI brain? Where do you have popcorn calcification in MRI brain? That is cavernoma or cavernous angioma. It is popcorn appearance is cavernoma. Okay. So that is, these are the various popcorns that we should know. Going on to the next one. What do you think would be the answer to this one? Let's see who's getting this right first. Okay, so I'm getting some mixed answers here. ये screen बीच में गायब हो जा रहा है, but I hope it stays with us till the end. ठीक है. Now look at the clinical history and look at the image. This is a 45-year-old female who has recurrent headaches, and this is the CT scan given. What are you seeing here in the CT scan? So basically in the CT scan, what are you seeing here? Do you think this is a contrast or a non-contrast CT? What do you think here? We can see some contrast here in the sinuses, right? So this looks like a delayed contrast scan. Okay, this looks like a delayed contrast scan. And look at the lesion. What do you think? Is it intraaxial or extraaxial? It's a extraaxial lesion. It is outside the brain surface. It is outside the brain surface. So this is something which is extraaxial, right? And the feature in a 45-year-old female, this homogeneously enhancing. Okay, this is a homogeneously enhancing mass. This is suggestive of extraaxial lesion. This is meningioma. Medulloblastoma is intraaxial. Posterior fossa is the most common site, right? So this is meningioma. Quickly tell me about some important points about meningioma. Very good. Why did I say that this is important here? Why meningiomas are more common in females? Because meningioma is progesterone receptor positive. That is what I said, Nehar. यहाँ पे बाकी कॉन्ट्रास्ट चले गया है, सिर्फ यहाँ पे आपको साइनसेस में यहाँ पे कॉन्ट्रास्ट थोड़ा दिख रहा है, सल्कल स्पेसेस से कॉन्ट्रास्ट चले गया है. So this is a delayed contrast scan. This image is a delayed contrast scan. Now anyways the question is saying that question में नहीं है, ठीक है, मेरे को लगा question में it is given that a contrast is given, right? So if it is mentioning, then you don't have to think about it. So because it's a progesterone receptor positive, it is in female, so it is the one tumor, brain tumor, which increases in pregnancy as well, right? So it can increase the size in pregnancy, and remember it has Psammoma bodies. What will you see histopath mein? It is Psammoma bodies is what we will see here. Very, very important. Where do you see the Psammoma bodies? the papillary tumor, the serous tumor, right? Meningioma, mesothelioma, they show the samoma bodies. Very good. What is the other sign that we see? Correct, Ashwini? The other sign that we see is the dural tail sign. Now look at this image here. This is a MRI. This is a contrast MRI. You have the black bone and look at this tail-like extension of the lesion. This is meningioma, dural tail sign. Remember, it is not specific for meningioma, but for our exam, we should at least know meningioma has dural tail sign. So remember, meningioma is meninges and meninges is dura. So dural tail sign is meningioma. Dura is meninges. So meningioma shows the dural tail sign. So this is the dural tail sign. Other thing, can someone tell me what sign is being depicted here in this image of meningioma? What sign is being shown here? So this is what I was telling you about the DSA, the black vessels. When you see, it is DSA. Okay, this is a MRI. So look at this lesion here. You can see this pattern, the spoke wheel pattern that you are seeing here. Look at the angio. There is a vessel which is then supplying the tumor. Again, the spoke wheel pattern. So remember that meningioma shows the spoke wheel appearance on angiography. Which brain tumor on angiography shows spoke wheel? So remember, it is meningioma. You have a dominant vessel which then spreads like this. Okay, that's good, Ashwini. So men have tail, so meningioma has tail, dural tail sign. Okay. Going on to the next question now. First of all, tell me, what investigation is this? What is this image showing? What investigation is this? Yes, what is that investigation there? Yes, very good. That's USD. That's a smart answer. That's a Viva answer. But what USD is that? What mode of USD is that? Why is that USD appearing orange color? Very good, Carol Basser, absolutely right. This is a contrast ultrasound. Contrast enhanced ultrasound. An orange colored ultrasound image is a contrast ultrasound. What is the contrast that we use in ultrasound? What is the contrast that we use in ultrasound? It is micro bubbles of the sulfur hexafluoride gas. It is micro bubbles of sulfur hexafluoride gas and it is excreted by the lungs, not by the kidney, and therefore it is safe in renal failure. Unlike the CT or the MRI contrast, which is excreted by the kidneys, this is excreted by the lungs. So that is why it is safe. Now, this contrast ultrasound is commonly done for liver lesion characterization, because the differentiation of the liver lesion characterization is based on arterial में कैसा दिख रहा है, portal phase में कैसा दिख रहा है, delayed phase में कैसा दिख रहा है, right? So we give contrast and we look at the pattern of enhancement. Okay, we look at the pattern of enhancement. So what are you seeing here? Oh yes, Manshad, you remember the mother-in-law. So the question here is refer to the provided image already given. It's a contrast enhanced ultrasound. This is a patient with chronic liver disease. So which of these is the most indicative of hepatocellular carcinoma? Which of these is the most indicative of hepatocellular carcinoma? What will be the answer to this? Okay, so Dr. M. Kumar says it is B, but which is not the correct answer. For hepatocellular carcinoma, what is the feature which is suggestive? Option A, option B, option C, option D. Right, it is basically option A. All of these can be seen with HCC. But what we need to know for HCC is it shows early wash in and it shows early wash out of contrast. Okay, it shows early wash in and early washout of the contrast. That means the HCC, as compared to the rest of the liver parenchyma, it enhances fast. Why does it enhance fast? Because it is supplied by the hepatic artery. Okay, so remember that HCC is supplied by the hepatic artery, while the rest of the liver is supplied by the portal vein. Now, when you give contrast from the vein to the heart to the arteries, it comes to the artery first, and that is why this shows early arterial enhancement. Now the liver has not even enhanced, but the HCC has enhanced because it is supplied by the hepatic artery. After that comes the liver वाला, जब तक liver का आता है तब तक इसका contrast चले जाता है. It has a rapid washout also. If you see sustained enhancement in a lesion, it is generally suggestive of a benign lesion. It is generally suggestive of a benign lesion. So look at this flow chart here. The lesion basically based on the arterial phase enhancement pattern. HCC basically has hyper enhancement in the arterial phase. It is early enhancement, right? Which is that liver lesion which shows the peripheral nodular enhancement, and then it keeps on in the centripetal form filling in. Centripetal filling, which is that one? That is hemangioma. The arterial phase is the early enhancement or nodular enhancement, and then it keeps on filling. Okay, that is hemangioma. Okay, that is hemangioma. Where do you see the central scar? Central scar in the delayed phase is seen in FNH or the fibrolamellar variant of the HCC. Okay, it is seen in FNH or the fibrolamellar variant of the HCC. Adenoma. Adenoma is associated with the history of OC pills usage. Okay, OC pills usage, adenoma is associated. It has the centrifugal enhancement that you are seeing there. Okay, so look at this diagram as well. So HCC is basically hypervascular in the arterial phase, and it shows a rapid washout as well. So early wash in, early washout is HCC. Early wash in, early washout is HCC. Most common, that is what we should know. Okay, that is what we should know. Right, going on to the next question now. What do you think will be the answer to this question now? Now, what are the important clinical clues here and what is the image showing? Very good. Absolutely right. So, Govinath, Bhavesh, Mustafa, correct. It is transposition of the great arteries. Look at the history here. A newborn infant appears cyanotic. So, this is a cyanotic heart disease. So, we know that the cyanotic heart diseases are the T wale. So, we search for some T. Now, this is presenting in the newborn itself. So, which out of TOF and TGA, which one presents in the newborn? Like the first 24 hours, the child can have a cyanosis commonly, that is TGA. So, based on that, I can answer this, that this is TGA. Let me have a look at the image here. Absolutely right. Look at the heart, which is appearing like an egg on string. The superior mediastinum is very narrow. So, what appearance are we seeing here is egg on string appearance. So remember that egg on string, when I write string, the TR helps me to remember that this is seen in transposition of the great artery. So the egg on string is seen in transposition of the great arteries. Okay, it is seen in transposition of the great arteries. Right, egg on string is also called as egg on site. So this is transposition of great arteries, and this is generally associated with what maternal condition is it commonly associated? It is associated with maternal diabetes mellitus. Overt diabetes mellitus, the gestational one does not have congenital anomalies because it comes later, right? Not in the first trimester, during the embryogenesis time. So it's associated with maternal diabetes. You have D type of TGA, you have L type of TGA. Can you tell me which is the type where you are worried about? It is more symptomatic, D type or L type? D TGA or L TGA? Absolutely right. So remember that it is DTGA. Remember D for dangerous. Okay, D for dangerous, L for lovely. Okay, L is lovely, D for dangerous. Why is that so? Because in the DTGA, so what is happening in the DTGA is the right atrium to the right ventricle, and from the right ventricle now comes the aorta. Right. दूसरे में क्या होता है, लेफ्ट एट्रियम, लेफ्ट वेंट्रिकल, और उसमें से आता है पल्मोनरी आर्टरी. इट इज ट्रांसपोज्ड, राइट, दिस इज ट्रांसपोजिशन. सो देयर आर टू पैरेलल सर्कुलेशंस गोइंग ऑन. एक राइट साइड वाला हो रहा है, एक लेफ्ट साइड वाला हो रहा है. सो रिमेंबर दैट दिस इज द वन which is dependent on PDA. You need to have some communication in between the two sides, right? So remember that this is very, very important. Mustafa, you need to have a look at the apex of the heart. In the boot shape heart, the apex will go upwards. That is a very important clue. Because of RVH, the apex goes up, right? Okay? So remember, it's a D type, which is dangerous. And how do you diagnose TGA in fetal echocardiography? In fetal echocardiography, how do you identify TGA? Remember, it's because of it is by the parallel aorta and the pulmonary artery. Normally, what you should see is the two vessels, they cross, right? Right ventricle से क्या आता है? Pulmonary artery. Left ventricle से क्या आता है? Aorta. But if you look at the arrangement when they are coming out from the heart, mediastinum wala, remember SAP is the arrangement of the vessels from the right to the left. The ascending aorta is to the right, the pulmonary artery is to the left. They are crossing each other. So what happens in TGA? They are not crossing each other, they are parallel oriented. Pulmonary artery right, aorta to the left, and that is why the superior mediastinum appears narrow, and that is why it is called as egg on string. String is the superior mediastinum, which is narrow because of the arrangement of the vessels. Okay, so that is why. So remember this point, extra edge point, parallel aorta and pulmonary artery on the fetal echo is suggestive of TGA. Okay, right. So parallel arrangement, parallel circulation, so it is ductus dependent. You want to keep the ductus open here. Can you tell me what drug do we use to keep the ductus open? What keeps the ductus open? Is it indomethacin, ibuprofen? Is it PGE? Which is the drug which keeps the ductus open? Very good, Mahesh. Govina, please don't make mistake there. Remember, to keep it open, open is PE. You will need prostaglandin E. That is alprostadil. PE, PGE keeps it open. So ulta of that, prostaglandin को ब्लॉक करने वाला NSAIDs. So basically NSAIDs का teratogenic effect भी आप ये पढ़ते हो. It is the early closure of the ductus arteriosus. They will do the ulta effect. So be it indomethacin, be it ibuprofen, they are blocking the prostaglandin. So it will close the ductus. It will close the ductus. Open is PGE. Okay, open is PGE. Going on to this one, basically this is the image showing you the parallel circulation which is going on. ये पूरा एक right side का, ये पूरा left side का. Next question, what do you think will be the answer to this one? So the clinical history is very, very important here. So Yashwant says it is B, pneumonia. Fever का history है इसमें? Fever का history है? नहीं है. So pneumonia is out. What is the answer here? Very good. Ranu, Mahima. Answer A नहीं है. Is it there is acute breathlessness भी नहीं है patient में? Look at the clinical history. It's a 45-year-old female who has progressive shortness of breath. There is something which is not acute, it's progressive, right? And there's also a history of connective tissue disease. So these clues are very, very important to help you make a diagnosis of Pulmonary arterial hypertension. Hypoxia we know is one of the causes which can lead to pulmonary arterial hypertension. So connective tissue disease, ILD associated, leading to hypoxia, leading to pulmonary arterial hypertension. Right, all the features are given here. There is elevated JVP because of the obstruction. There is a P2 component is loud, telling you that the pulmonary artery pressure is high. There is loud pulmonary regurgitant murmur. I hope you remember that. In pulmonary arterial hypertension, the pulmonary artery is dilated, and because it is dilated, the valve is not able to close. So there is the regurgitant murmur. What is that murmur called as? The regurgitant pulmonary murmur in pulmonary arterial hypertension. उसका कोई नाम है? Right, pulmonary hypertension, PH, phone वाला. Phone किसने discover किया था? Alexander Graham Bell. So that is your Graham Steele murmur. Right, that's your Graham Steele murmur. Pulmonary hypertension mein, that's your Graham Steele. Absolutely right, Mushahid. Right. So remember phone, that is pulmonary hypertension, phone is Graham Bell. So that is your Graham Steele murmur. Okay, that's your Graham Steele murmur. So what is the X-ray showing? Now we answered this question based on the clinical history itself. Let's have a look at the X-ray. What is this showing basically is, look at this prominent hilum here because of the enlarged pulmonary artery there. Look at the enlarged pulmonary artery on the left as well, right? So basically the dilated pulmonary artery is what we are seeing here. What will you see in the lateral chest X-ray? There will be RVH. The RVH is what you will see because of the back pressure, right? No, why can it not be sarcoidosis? सबसे पहले तो clinical features उसमें fit नहीं हो रहे हैं. Sarcoidosis में जो bilateral hilar lymph nodes होते हैं वो rounded होने चाहिए. The lymph nodes are rounded. The vessels, they will be tapering like this. They will not be rounded. Okay, so the lymph nodes will have that classical rounded appearance. Right, so this is pulmonary arterial hypertension with the prominent pulmonary vessels, and that is also called the jug handle appearance of the pulmonary artery. What else you have is the peripheral pruning. The peripheral vessels in the chest are pruned, they are cut down. So peripheral pruning is what we have. So this is pulmonary arterial hypertension. Next question here, easy one. What do you think will be answer to this one now? Right, so you will see the questions where the history is very important. Tympanic note on percussion is the giveaway here. The tympanic note tells you that it is the presence of air, right? It's the presence of air. Air is pneumoperitoneum. Air matlab pneumo. So basically you know the diagnosis is pneumoperitoneum from the clinical history itself, and pneumoperitoneum is because of perforated peptic ulcer. Okay, perforated peptic ulcer. Look at the X-ray here. You have this diaphragm here. This is the gas under diaphragm. This is the gas under diaphragm. This is a CT scan that you are seeing here with the white bone. And all this black that you are seeing basically is the air. Okay, that's the air. So when the patient is lying supine, all the air has gone beneath the abdominal wall. So this is pneumoperitoneum. Okay, this is pneumoperitoneum. What is going to be the treatment here? Treatment is IV fluids, resuscitation of the patient, and then you take the patient for surgery. So IV fluids, resuscitation first, and then the surgery. Okay, then the surgery. So remember, perforated peptic ulcer is what leads to pneumoperitoneum. Pneumoperitoneum. Okay. If it was, I'll come to the discussion here when we have the next one. Right. What is this sign that you are seeing in pneumoperitoneum in the X-ray? What sign is being depicted here? So look at this lucency of the air. Lucency, air lucency coming like a football. This is the football sign. Okay, this is the football sign which is seen in the supine X-ray in massive pneumoperitoneum. Okay, that's the football sign that we are seeing here. Okay, very, very important. Okay, let's have a look at this one. What do you think will be the answer to this one now? What is this one here? I see mixed answers here. C है कि D है? Right, the correct answer here is acute appendicitis, because the history is enough telling you that there is acute right lower quadrant pain, that is appendicitis. In diverticulitis, where is the pain? It is in the LIF, the left iliac fossa, because what is the most common site of diverticuli? That is the sigmoid colon. In sigmoid, the pressure is high. Whenever any organ has high pressure, it wants to vent out, right? Like we went out, जब हमारा pressure बढ़ जाता है. Similarly, any organ when the pressure is increasing, it wants to vent out. So it vents out that pressure by forming the diverticuli. So in sigmoid, because the feces are formed by that time, the pressure is high. So it has diverticuli, very, very common. Okay. So remember, that will be LIF pain. This will be right hypochondriac pain. This will be the epigastric pain going to the back. So the clinical history is enough. Absolutely right. Then you also have rebound tenderness present. The WBC count is high. What scoring do we use? Absolutely right. We have the Alvarado score, A for A, used for appendicitis. What features are given a score of 2 in Alvarado score? What components are given a score of 2? So remember T and W, that is tenderness and the WBC count. Okay, remember it is tenderness, not the rebound tenderness, which is given a score of 2 in the Alvarado score. It is tenderness, not the rebound tenderness. What are you seeing here in the ultrasound? Let's have a look at the image here. So basically this is the tubular structure, blind ending structure that you are seeing here. Appendix is described as a blind ending tubular structure. Why blind ending? Because it does not go into anything else. It does not go into the ileum or the colon. It is blind ending, right? Surrounding that, this is the echogenic mesentery, suggestive of inflammation. Any organ which is acutely inflamed will be dilated. It will be distended, right? The diameter is going to be more than 6 mm. The diameter is going to be more than 6 mm on ultrasound. Any organ which is acutely inflamed has surrounding fluid. So there will be surrounding fluid which is present. Now what happens is in appendicitis, when the appendix is inflamed, the inflammation goes to the cecum also. So if this is the appendix, this is the cecum. Cecum के wall में भी inflammation जाता है. So there is wall thickening in the cecum also. So look at this cecum. Where did I reach here? Okay, give me a minute. Right. So look at this cecum here. Look at the contrast in the cecum. It appears like this arrow mark. This is basically the wall of the cecum which is thickened. So this is called as the arrowhead sign or the cecal bar sign. It got stuck. Why did it get stuck? Am I back now? Okay, that's great. Chalo. So we are back. Right. So we were discussing about the appendicitis. Right. So this is the arrowhead sign or the cecal bar sign. Is this clear with everyone? So this is acute appendicitis. If they ask you what is the best investigation for acute appendicitis, the best is the CT scan, because in many patients the appendix is retrocecal. So if this is the cecum, behind that sitting is the appendix. So when we do ultrasound, the air in the cecum will not allow the appendix to be visualized. So many times if the appendix is retrocecal, we might not be able to see the appendix on ultrasound, but in CT scan, irrespective of the position, we'll be able to see the appendix. So the best investigation is CT scan. Okay, can you hear me, everybody? That CT, you want me to repeat the CT V? Okay, so look at this one. What do we have here is, this is the contrast. Basically this is the oral contrast in the cecum. Look at the appearance of the cecum. It is this arrowhead appearance because of the wall thickening, the inflammation going from the appendix to the cecum, that gives the arrowhead sign. This is the appendix which is distended, filled with fluid. It will have surrounding fluid also and the echogenic mesentery. Okay, this is appendicitis. For diverticulitis, remember it's going to be LIF pain, which is more common. We use Hinchey's classification there. Okay. Coming on to the next question, what will be the answer to this one now? So look at the history again. The subperiosteal resorption is a very important clue here. 50-year-old female, there's bone pain, fractures, and you can also see there are kidney stones, bone pain, bones, stones, moans, groans, right? The psychiatric features, the abdominal pain, the kidney stones, the bone pain with subperiosteal resorption is telling you that this is a diagnosis of hyperparathyroidism. Hyperparathyroidism है ये, osteoporosis नहीं है. Bisphosphonates are used in osteoporosis. They do have some role in hyperparathyroidism to prevent the resorption. That is how they act. But the primary treatment in hyperparathyroidism will be the removal of the parathyroid adenoma. So एक के पीछे सब लोग गलत मत आंसर मार्क कर देना. This is parathyroidism, hyperparathyroidism. You need to remove the parathyroid adenoma. What nuclear scan do we do for parathyroid adenoma? It is the SystemEB scan. Okay, what nuclear scan? Remember, it is the SystemEB scan that is done for hyperparathyroidism. Look at the image here. What are you seeing in the image? This lesion, lytic lesion in the bone, which appears like a bone tumor in hyperparathyroidism, is called as the Brown's tumor. Actually, it is not a tumor. It is just the granulation tissue and hemosiderin deposition there. It is called as Brown tumor, right? And what is the skull appearance that you are seeing here? The tiny black lesions like the pepper. So that is the salt and pepper appearance of the skull. Okay, that is called as salt and pepper appearance of the skull, the tiny lytic lesions. Okay, and you have the subperiosteal resorption. That's a major clue there. What is the effect of parathyroid hormone on calcium and phosphorus as compared to vitamin D? Remember, parathyroid, okay, parathyroid is PT, that means it has opposite actions. It increases calcium, it decreases phosphorus. Okay, it increases calcium and it decreases phosphorus. Right, very good, Mahesh. It is opposite effects. It increases calcium, it decreases phosphorus. Okay. Going on to the next one. What do you think will be the answer to this one now? Is there still any issue, guys, in the streaming? No, right? Issue आ रहा है ना streaming में? Chalo, let's finish off this last question, the 10th question here, right? And I hope this will be all good. Very good. What is now? Okay, ठीक है. जब भी मैं बंद करने की बात करती हूँ सब ठीक हो जाता है. What are we seeing here basically is Look at this one. The increased gap between the middle finger and the ring finger, that is basically the trident hand wala feature. That is the trident hand or the starfish hand, which is a feature of achondroplasia. Okay, it is a feature of achondroplasia. Achondroplasia is a very common cause of dwarfism. Okay, it's a common cause of dwarfism. What bones are affected? What kind of dwarfism is it? Is it rhizomelic? Is it mesomelic? Is it acromelic? What kind of dwarfism is it? What kind of dwarfism is it? It is the long bones which are affected. Okay, so long bones matlab attached to the root. They are like the root of the body. That is called as rhizomelic dwarfism. Okay, that is called as rhizomelic dwarfism, right? Correct, absolutely right. What is this X-ray showing? What is happening to the femur here, the end of the femur here? This V-shaped appearance of the end of the femur. Right, this V-shaped. What is this V-shape called as? This is called as the chevron sign. Okay, that is called as the chevron sign. So remember, this is achondroplasia, and in achondroplasia, what is the most probable diagnosis and the gene affected? The gene affected is FGFR3 gene. Okay, that is FGFR3 gene which is affected. Right. So the trick to remember achondroplasia is, remember achondroplasia, CH and CH. It has champagne glass pelvis. Okay, it has champagne glass pelvis and it has the chevron sign. Okay, and it has the chevron sign. What is the chromosome number for achondroplasia and what is the inheritance pattern for achondroplasia? Yes, what chromosome is it and what is the inheritance pattern? Very good, Snowcast. It is autosomal dominant. And what is the chromosome number? Very good, Dr. Priyanka Lucky. It is chromosome 4. So remember, it affects the 4 limbs. That means there is dwarfism affecting the 4 limbs. So it is chromosome number 4. And generally the structural disorders involving the muscles, the skeletal system, bones, they are generally autosomal dominant. So remember, it is chromosome number 4 and it is autosomal dominant. Okay. This is achondroplasia. COL1A1, COL1, that is collagen type 1, is present in the bones, BONE. So this is affected in osteogenesis imperfecta, where you will have multiple fractures ka history. Okay. FEX, where is FEX affected? There is hypophosphatemic rickets, X-linked wala, vitamin D resistant, X-linked basically, hypophosphatemic rickets is the FEX gene. And the FBN1 gene is basically the fibrillin wala, which is affected in Marfan syndrome. Okay, Marfan syndrome is fibrillin. Look at this one. This is the chevron sign. This is the exaggerated lumbar lordosis in achondroplasia. This is the trident hand. Look at the flat acetabulum with this appearance of the iliac blades. What is this appearance called as? The tombstone appearance of the iliac blades, and this is called as the champagne glass pelvis. Okay, this is the champagne glass appearance of the pelvis. Okay, so this is basically for, this is achondroplasia. Okay, this is achondroplasia. Is this clear with everyone? चलो, क्वेश्चन गलत हो गया. नेक्स्ट बताओ ये क्या है? Easy one. Question itself is easy. What do you see here? There is a curvature of the spine. To evaluate the severity of the curvature, which angle is commonly used? It is the nahi, history galat thi. So that is one question where everybody will get correct answer. Yes, that is the Cobb's angle. Okay, that is the Cobb's angle. Easy trick again here to remember is, remember scoliosis. Scoliosis, C-O-C-O, is the Cobb's angle. Okay, scoliosis is the Cobb's angle. So this one that you are seeing here, this is the Cobb's angle being measured At the end of the curvature, we take the line along the end plates, that is the Cobb's angle. So scoliosis CO, Cobb's CO. Do you remember orthopedics may also we read, where do you use the kite angle? Kite angle is used for which condition? So remember that is used for CTEV. So remember the CTEV is like CITE, that is the kite. Okay, that is the kite angle. Okay, so remember kite is CTEV. So this is Cobb's angle. SKND, are you a dental student? Ferguson's angle, remember Ferguson's FE is used for femur neck fracture. Research's angle is used for the maturity, the skeletal maturity of the pelvis, right? Using the iliac crest, uske liye use karte hain. And you have the Adams test, forward bending test, not the Adams angle. ठीक है? चलो. So this is basically the Cobb's angle that is being measured along the end plates of the vertebra, and you can take a right angle to them and you can measure the angle there as well. ठीक है? Next one, what do you think will be answer to this one now? हाँ, Milwaukee brace, Milwaukee. Very good. Absolutely right. That is the D marks, because what are you seeing here? What are you seeing here? Yes? What is this deformity here and what is this deformity here? Absolutely right, the bottomers and the swan neck deformity. Just by the image you can identify this. And a very important history here is it is bilateral hand pain and swelling. So it affects both of the hands. It's generally bilateral, symmetric involvement, right? MCP joints are involved, the DIP are spared. Another important feature in rheumatoid arthritis. So look at this one. What is this one? Is it swan neck or is it bottomers? So easy one. Remember that for swan neck deformity, if you remember one, the other one becomes easy. So for the swan neck, do like this to remember कि ये neck के जैसे ऐसे bend हो गया. So this is in the swan neck. There is DIP flexion. So there is PIP hyperextension. Opposite is what happens in the bottomers. In bottomers, so it will be DIP extension and the PIP flexion. This is what will happen in the opposite. So remember, swan neck is like this. It is the DIP flexion. So this is the DIP flexion. So this is swan neck deformity. This is the PIP flexion. So this is going to be bottomers deformity. The PIP flexion is going to be bottomers deformity. So remember that in rheumatoid arthritis, the DIP. ठीक है. Mesh, next time कोई और network try करेंगे, right? So remember, in the DIP is paired in rheumatoid arthritis. DIP is paired in rheumatoid arthritis, and the primary drug used in rheumatoid arthritis are the DMARDs, basically, which affect the underlying disease process. What is the antibody in rheumatoid arthritis most specific? It is anti-CCP antibodies which are positive. है ना? Chalo. Let's go to the next question. What do you think will be the answer to this one? Now, what is the history here? This is a 55-year-old male. Great toe is a very, very important history here. Right, there are punched out erosions which are there. There is tophi formation, uric acid crystal deposition, or kya clue chahiye to help you make a diagnosis that this is a case of gout. Right, it's the other way around. The more lengthy the questions, the more clues you have basically to come to the diagnosis. So this is gout. Remember gout, GTO, affects the great toe. Gout affects the great toe. The first MTP joint is commonly affected. It is uric acid crystals, and when you have this कौन सा birefringent crystals होता है इसमें? Negative की positive. Remember, gout is negative, right? Basically, it is like negative. So, it is negative birefringent crystals, negative and negative NE, needle shape. It is needle shape negative crystals. CPPD on the other hand, the pyrophosphate wala, it is positively birefringent, and imagine like it's a parallelogram. That means it is rhomboid shape. Okay, it is rhomboid shape. So, positive parallelogram in CPPD, negative needle shaped in gout. Okay, and so in gout, what is the most appropriate treatment for managing the underlying inflammatory condition? The most important treatment here is the urate lowering therapy. What enzyme will you block? The xanthine oxidase inhibitor drugs. Which are those drugs? It is allopurinol, and which is the other drug? The febuxostat. So remember XO-stat, that is xanthine oxidase ko static karne wala. So these are the major mainstay treatment, but we do not use allopurinol in the acute gout. Acute gout mein we use NCC. That is NSAIDs, colchicine and corticosteroids. These are used in acute gout because basically in acute gout you need anti-inflammatory action. So NSAIDs, steroids, colchicine, all of them have anti-inflammatory action. The question here, Lucky, is most appropriate for managing the underlying inflammatory condition. So you don't want more uric acid to be formed. So the mainstay of treatment is allopurinol, though you do not give allopurinol in the acute gout, right? The question is asking for managing the underlying inflammatory condition. Okay, so look at this one. This is what you have in gout. Basically, the erosions with the overhanging edges, that is called as rat bite erosions. It is called as rat bite erosions, or it is also called as the Martel sign. Rat bite erosions or Martel sign is what you see here. And this is the first MTP which is commonly involved. Okay, so that is punched out lesions. Okay, so this is gout. Going on to the next question. What is this one here? Again, what is the most likely diagnosis? Look at the shape, look at the shape, look at it crossing the sutures. So this is going to be absolutely right, Lucky. It is subdural hematoma. Look at the shape and it is crossing the sutures as well. So this is subdural hematoma. Okay, this is subdural hematoma which crosses the sutures. Subdural hematoma crosses the sutures, and it is because of the rupture of the cortical bridging veins. It is because of the rupture of the cortical bridging veins. While epidural hematoma is idylly shape, it is biconvex shape. It is due to rupture of middle meningeal artery, which is a branch of maxillary artery, which goes via the foramen spinosum. Remember, we have spine in the middle. So, middle goes through the spinosum foramen. Subdural hematoma, S for S, is sickle shape. That means it is crescent shape. In subarachnoid hemorrhage, you will have the history of thunderclap headache. The thunderclap headache history will be common there. Intracerebral hemorrhage is basically the most common cause is hypertension. Okay, the most common cause is hypertension. And basal ganglia is the most common site. This hemorrhage here is extraaxial, it's not intraaxial. So that is why this is definitely not intracerebral. This is not subarachnoid hemorrhage. So this is subdural hemorrhage. Okay, this is subdural hemorrhage. What hemorrhage is this one here? Which is this biconvex shape, and you can see there is associated fracture baju mein. That is EDH. Okay, that is EDH. So EDH is generally more acute. In STH, you can have acute STH or you can have a chronic history also, because basically it is venous rupture and the veins can rupture very easily. So even chota sa trauma might lead to STH, But generally in EDH, there is associated adjacent fracture which is common. To rupture that middle meningeal artery, there has to be significant injury. Okay. Going on to the last question here, tell me what do you think will be the answer to this one? Right, very good. Absolutely right. Lucky, Mahesh, Dr. Priyanka. This is Wernicke's encephalopathy. Again, the history here. Chronic alcoholic patient. Unsteady gait, ataxia, confusion, ocular abnormalities. The clinical history is enough to tell you that this is the triad of Goa. Goa mein jaake alcohol piya. So remember, this is Goa triad is seen in alcoholics, which is global confusion. What is the Goa triad for? Global confusion, ophthalmoplegia, okay, global confusion, ophthalmoplegia, and there is ataxia. So this is Wernicke's, which is because of thiamine deficiency, vitamin B1 deficiency, and the classical involvement of the periaqueductal gray matter, the involvement of the mammillary bodies. So remember, in Wernicke's, W ka mirror image M, Wernicke's involves the mammillary bodies commonly. So that is the key feature here, that is Wernicke's encephalopathy. And in patients of Wernicke's or vitamin B1 deficiency, you will give thiamine first and then glucose, or you will give glucose first and then thiamine. What will you give? So remember that first you have to give thiamine and then you have to give the glucose, that is the dextrose has to go baad mein. Because thiamine is very important for utilization of glucose. Which enzyme is it? Pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase. These require thiamine. So pehle thiamine do aur fir glucose do. Okay, pehle thiamine aur fir glucose. And look at this image here. This is where you have the mammillary body, that is the MB in front of the MB. This is the mammillary body in front of the midbrain. Okay, this is MB in front of MB. So that is midbrain ke aage mammillary body, and you have pons and you have medulla. Okay. And this is again the mammillary bodies in front of this heart shape, that is the midbrain. Okay, that's the midbrain. So mammillary bodies are very commonly involved in Wernicke's. Right. So those were the top 15 questions here from radiology, guys, and I hope all of you are aware of the pro plan on the PrepLadder platform, where it's the India's only clinical question bank that you have, and you can get this at around 13K for 6 months. So basically all you need for your preparation for the upcoming next exam, everything except the videos, that is the QBank will be there, the next edition QBank, the next edition test series, the treasures, the previous year questions, everything will be included in the pro plan. So except the videos, everything is there, and I believe the QBank next edition is something which you can see are very high yield clinical integrated questions that help you understand the topic better. Right. So thank you so much everyone. Nihar, aaj ke liye itna hi kafi hai. Time for some self study now. So we will have more sessions coming in. So like I said, stay connected on this YouTube channel. So subscription, subscribe the channel with that bell icon so that you get the notification. And yes, do not forget to like this video, because I told you that that's a way of expressing your love for this video and for me. Okay. So thank you so much everyone. Daffodil not available yet. I will update you on the Telegram group. Okay. So Dasha, Telegram group pe update de dungi. Okay. Thank you so much everyone. Goodbye. Take care and keep studying, keep revising and keep winning. Thank you.